We're live. Good afternoon and welcome to today's coronavirus technical briefing. We are joined today by the Minister of Health, the Honorable Kim Wilson, JP, MP, by the Chief Medical Officer, Dr. Diallo, and the Chief of Staff of the Bermuda Hospitals Board, Dr. Miller. We will begin with remarks from Minister Wilson. Minister?
Thank you. Good afternoon, everyone. I begin my remarks today by reporting that since our last update on Monday, Bermuda has unfortunately another 2 COVID-19 related deaths. I extend my sincere condolences to the friends and families of their loved ones and wished for you to know that your thoughts and our prayers are with you. This Omicron variant continues to take a toll on our community. It spreads quickly, and we have quite a number of active cases, primarily through community transmission. There were 4,174 test results received by the Ministry of Health since the last update, and 290 were positive for COVID-19. These results are from testing done on Sunday, where there were 39 positive out of 998 results, which represents a 3.9 positivity rate. On Monday, 156 positive out of 1,859 results, which represents an 8.5 positivity, and Tuesday, 95 positives out of 1,317 results, which represents a 7.2% positivity rate. 32 of the new cases are classified as imported with history of travel in the previous 14 days. The additional 258 new cases are classified as either local transmission, and there were 98 in that particular category, or under investigation, and there were 160. Additionally, there were 603 recoveries. There are currently 1,404 active cases, of which 1,397 are under public health monitoring, and 7 are in hospital, with 2 in intensive care. From January 11, 2021, when Bermuda's vaccine campaign first began, up until January 22nd, 2022, Bermuda has experienced 337 COVID-related hospitalizations, and that includes repeat admissions, of which 284, or 84% of persons who were hospitalized were not vaccinated fully, and 53, or 16%, were fully vaccinated. And in addition, since we began our vaccination program again on January 11th last year, we have had 101 deaths, of which 86, or 85% of persons who were not fully vaccinated, and 15, or 15% of those persons were fully vaccinated. And sadly, the total number of deaths related to the coronavirus illness is 116. I will now provide an update of our vaccination program. Since January 11, 2021, Bermuda residents have received a total of 120,535 vaccinations. And of that 120,535 vaccinations given as of January 22nd, 2022, 52% of those persons vaccinated were women, and 48% of those persons vaccinated were males. 87.1% of all residents over the age of 65 years have had at least one vaccination, and 85.8% are fully immunized. To date, 72.9% of the population has been vaccinated with 1 dose, and 71.6% of the population has been immunized with 2 doses. And in addition to this, 64.8% of those persons eligible for a booster have received their boosters. And as a reminder, vaccine booster appointments are available for Bermuda residents 12 years of age and older who have had their second dose more than 6 months ago. For those persons 65 years of age or older, it is by appointment or walk-in at the Pier 6 on Front Street. And for those persons between the ages of 12 and 64 years of age, it is by appointment only. I encourage anyone who wants to get vaccinated to register their interest at gov.bm/vaccines. And if you are eligible for your booster, please get it. Studies released by the CDC show that the booster provides improved protection against severe illness and hospitalization due to COVID-19. Please note, we are not currently administering fourth doses or second boosters. Before I end my remarks, I want to remind everyone that if you test positive on a COVID-19 test, whether it's self-administered or supervised antigen or a PCR test, by law, you must isolate immediately. If you are immunized more than 2 weeks since your second dose, isolate for 7 days, and that is the date of your positive test sample, which is day 0. Book a supervised antigen test appointment for day 7. If you have no symptoms and the day 7 test is negative, you end isolation and follow the public health guidance. And if you do have symptoms, contact COVID-19 case management at gov.bm for guidance. If you are not immunized or have never been vaccinated, these are your instructions. Isolate for 10 days from the date of your positive test sample. Book a supervised antigen test appointment for day 10. If you have no symptoms and the day 10 test is negative, end isolation and follow the public health guidance. And if you do have symptoms, contact COVID-19 case management at gov.bm for guidance. To be clear, for those who are close contacts but not actually positive for COVID-19, the quarantine requirements for you are as follows. If you are immunized and boosted within 6 months, no quarantine is required, but we recommend at a minimum that you take a self-administered antigen test on day 7, not a verified antigen test as was previously reported. And also we recommend that you do antigen testing daily for self-monitoring and follow the public health guidance. If you are immunized but not boosted, you must quarantine for 7 days and take a verified antigen test on day 7. And if you are not immunized or vaccinated, you must quarantine for 10 days and take a verified antigen test on your day 10. As a reminder, a complete list of the approved antigen tests can be found at the Bermuda Health Council's website, bhec.bm/approved antigen test. The listed tests have met the required standards for validation of the identified regulatory bodies. Do not hesitate to contact your doctor for guidance regarding COVID-19. And if you do not have a doctor, the hospital has set up a phone number at 239-2009 to assist persons with information on the proper treatment for your symptoms. With respect to the public health legislation, the Ministry of Health is currently conducting a review of the Public Health COVID-19 Emergency Powers Phased Reopening Regulations 2021 with a view to making adjustments to take effect from February 4th, 2022. We are assessing a number of metrics, including our vaccination rate and the COVID-19 indicators for our current outbreak. Additionally, and importantly, we are taking into account the government's shift to living with COVID, which requires all of us to take personal responsibility for our actions. Not only is the ministry reviewing the emergency powers regulations, but we are also reviewing the quarantine COVID-19 number 3 order 2020. It is the quarantine order which establishes the traveling testing regime for air arrivals, cruise ship visitors, and mariners. And the aim is to reset Bermuda's travel requirements for April 1st. Finally, I want to assure the public that a plan for the transition of leadership for Bermuda's molecular diagnostic laboratory is already well developed. The Bermuda Health Council, assisted by the ministry, has taken on this responsibility, and we expect a smooth changeover next week. The staff at MDL is experienced and well-trained, and Dr. Weldon is to be commended for her leadership to date and her assistance with this transition. More information regarding the new leadership will be announced very shortly. In closing, I cannot stress enough how important it is for all of us to do our best to stay safe and healthy. We must look out for each other. We must act responsibly and adhere to public health guidelines. This current outbreak is not over, and to get through this, we must all take responsibility for ourselves as well as others in the community. Each of us has a role to play in stopping the spread of the coronavirus. Follow the public health guidelines, wear your mask, practice good hand hygiene, and maintain physical distancing. Thank you.
Thank you, Minister Wilson. Now we'll have a few words from Dr. Ayoola. Dr. Ayoola.
Good afternoon, Bermuda. This afternoon, I will be presenting a short presentation. Part of it would expand a little bit on what the minister has said around changes that have happened with our quarantine measures, and also I will touch a little bit around describing the Omicron variant of this SARS-CoV-2 virus, and finally a little bit about our vaccinations program in Bermuda. So if you indulge me, I'm just going to share my screen. Okay. And right. Hopefully you can see my screen now. And so if I start with the first slide. Okay. So the first thing to mention is antigen, as building up on what the minister said, is that antigen tests are now being accepted as positive. So it's no longer necessary for you to confirm your antigen test with a PCR test because of the present level of community transmission that we have. And so that allows us to make that link without needing to have a PCR test. So you would also notice, as the minister said, that there'll be more use of verified antigen tests as opposed to the PCR tests that we have been used to. She's also outlined the shortened isolation and quarantine periods for fully vaccinated people and for changes for the fully vaccinated and the boosted in the last 6 months. The reason why we're doing this is basically because this meets with the WHO case definition. So basically, we've always gone with the first definition, which is the A, positive PCR type test, but also we have we're able to now use the second criteria because we are in community transmission at the moment. A little bit about antigen tests. We have talked about this before. They differ slightly from PCR tests in the sense that although they are not able to detect the full range that the PCR tests can detect, the antigen tests are able to detect the virus when there's a large amount of it in the system. And this also corresponds with the time that the patient is most infectious, and that is important to note. Okay, so here is a list of the testing locations that we have on island, and most of them will have ability to be able to do verified antigen tests for people, and the booking is as usual via gov.bm, and you can book for this. Thank you. So moving on swiftly to talk about the Omicron variant. Late in November, WHO designated this variant. The technical name is B.1.1.529 as a variant of concern, following advice from the technical group on virus evolution. It was named Omicron, and there are 4 basic subtypes of this virus. So there's the original 1.1.529, the BA1, the BA2, and the BA3. The most important thing to know about this virus is about its ability to transmit easily, and I'll come on to that in a few minutes. And how well the vaccines and prior infection protects people from this virus, and also how virulent this is, how many people end up in hospital or dying from this condition, and how well the population understands the dynamics of its transmission. So what's different about Omicron? Unlike previous variants of concern, this virus tends to have an affinity for the upper part of the airway as compared to the Delta and the wild type that has an affinity for the lower part of the airway. And that's why we had so many people coming up with pneumonia type illnesses because the lungs were infected with Delta and the wild type. Omicron tends to be affect the upper part of the airway. And what that means is that there's so much more concentration on the upper part of the airway. You can breathe out a lot more of viral particles, and therefore it's also much more infectious. There's plenty of evidence now that shows us that it's able to escape at least certainly some of the protections offered by vaccination, and in many cases previous infection as well. The caveat to that is that, and I'll come on to that in a few minutes, where we'll talk about how different levels of viral vaccine protection protects us from Omicron variant. The other point to make about Omicron is that we expect that most of the other therapeutic agents that we have, such as steroids and the new molecular type of drugs that we have against it, and antivirals, we still expect them to work. However, some monoclonal antibodies that were originally developed against this do not work as well. Again, it goes back to the amount of changes in the spike protein of Omicron that makes it much less susceptible to these monoclonal antibodies. So diagnosing Omicron is basically similar to what we have done for all the other variants. So we look for a type of what is not present. So it's called the S gene target failure. So if we don't find that, then that is strongly suggestive of Omicron. WHO, the FDA, and also the Medicines and Health Regulatory Authority of the United Kingdom have conducted quite a lot of tests with antigen tests, and the ones that we recommend on Ireland do work at identifying Omicron variants. I did mention at the start of my presentation that there are 4 types. The only way you can tell what type from the other is by doing a gene sequencing. You might remember just before Christmas, the MDL laboratory was able to conduct its first sequencing here on Ireland. We're still partnering with the New York Genome Project and also with CARPHA to get all the sequencing that we need done. Okay, so going back to the point I made earlier on, there is evidence showing that there is less reduction. So there's a reduction in the neutralizing antibodies. And this is basically the protection that we get from individuals who received primary vaccination or those who had prior infection. Now, the newer studies that have been done shows that the protection goes up quite significantly for people who've been boosted. And this is why we've been promoting booster vaccination across Bermuda. So I'll give you some of the latest data. This data actually was published yesterday. This is based on the UK data, and it combines all the vaccines against Omicron and Delta. As you can see here, primary course of vaccination for 2 doses shows decline significantly for symptomatic disease after 6 months. But once we get the boosters up, the protection increases quite dramatically. However, it's important to note, because antibodies are not the only part of your immune system. There are other parts of the immune system that protection against mortality and hospitalizations still remains very, very high. This is the same thing it is actually much more pronounced when we had Delta. So the first table is for Omicron, the second is for Delta. So this is our epidemiological curve in Bermuda. As you can see, we had basically 5 successive waves, if we count the first lot of cases that we had. And what is even more interesting is that each wave seems to be getting successively worse. In addition, the duration between each wave appears to be contracting. So there is a lot to be said from this graph. This also is a very interesting graph that my colleagues have produced, and it looked at daily COVID-related admissions. As you can see, we generally got a very big hit from the Delta wave. However, the admissions that we're seeing from this wave of Omicron is slightly less. It's early days yet, but it's much less than what we had with Delta or when we had the Alpha variant earlier on last year. So this is not unique to Bermuda. There's a lot of epidemiological data that shows that there's a decoupling between the number of cases that we see and hospital admissions for Omicron. And that's partly because this virus has more affinity for the upper part of the airway rather than the lower part of the airway that we find in other variants. And this other reason for this is that there is a lot more vaccination going on across the whole world, really. And in Bermuda, we've had a very good vaccination program, and that provides a lot of protection for the population. We've also had quite a lot of people who got infected during the Delta wave, and therefore they have some protection from that infection. It must be emphasized that the people who had significant protection after they've been infected are people who ended up in hospital, are very sick from this disease. So I'll move on then to talk a little bit about our vaccine coverage, and the minister has talked about this a lot. What I just wanted to highlight is that we're making significant progress in terms of our booster coverage. So just under 43% of our total population have been boosted. If we look at the vaccination, about 81% of our eligible population have been boosted and have been vaccinated, and 72% of the total population have been vaccinated. Looking at the vaccination by age, and we can see that quite impressively, 80s and overs, almost 90% of them have been fully vaccinated, and same thing with people aged between 65 and 79. People between 50 and 64% also have pretty good vaccination coverage. We're still trying to get up to speed with under 50s, and that's a combination of the fact that we started the vaccination much later in that age group, and some vaccine hesitancy in that age group as well. My final slide will be looking at the booster coverage by the eligible population. Again, this is quite impressive. More than 3/4 of our 80 plus year old and the 70 plus year old have been vaccinated. If you look at the 60 to 69 year olds, just a little bit under 3/4, and the same thing with our 50 to 59 year olds, it's about 70%. The number or the proportion of people who've been vaccinated in the other deciles is less, and that it represents the fact that many of these people also were vaccinated later, so their eligibility will be less, and also this perception of risk and some vaccine hesitancy explains some of that data. So thank you very much. I would end this now, and I will hand over to my colleague, Dr. Wesley Miller from the hospital, to give us a perspective from PHP.
Good afternoon, ladies and gentlemen. I certainly echo the words of the Minister and Dr. Ayoola, and must thank them both and their teams for the wonderful job, along with the cooperation of the public that has certainly served to keep us safe here at DHB and put us in a position that we are still able to provide normal services for the community. And as he noted, the Omicron variant has certainly been much more infectious than the previous variants. However, we have noted that the hospital stay for the people with the Omicron variant was significantly less. And therefore, we so far have not seen the overwhelming numbers that were seen in the last wave. Also, in terms of the severity of the illness, they seem to have less severity, and therefore, as it stands even now, though we have adequate preparation for additional intensive care beds, we have not had to use that so far, but the preparation is in place and ready to go. So should we need that, it wouldn't be a crisis. We could handle that. Staffing has been a challenge, and certainly we did anticipate that and put in place measures to mitigate that. To our benefit and the benefit of everyone, the new regulations on quarantine meant that we could have some staff who may have just had exposure come back to work earlier, of course wearing the appropriate PPE in the particular settings. And the ready availability of the antigen testing, which by the way I would encourage the public to use more often, certainly was of benefit to us because we could keep our staff and patients safe by doing frequent antigen testing, and in some instances daily antigen testing for particular categories of staff. In so doing, we have been able, notwithstanding the large number of cases in the community, to maintain normal services in terms of being able to continue elective surgery, which during the Delta wave, we had to put on hold. You may recall at that time, we were able to do emergencies and urgent cases, but up until the beginning of November, we had to put elective surgery on hold. At the present time, we are proceeding with elective surgery as per normal, or only constraint being the availability of beds to do same-day cases. We do some, but we are constrained by the fact that we do have patients who sometimes not appropriate for the acute care wing, but they are stuck in these beds because they have no suitable alternative arrangement. In other instances, they probably can go home, and I will take this opportunity to implore on the relatives is that those who have their loved ones in hospital who they have been told they are discharged or fit enough to go home, please come and take them home, because in so doing, you will allow us to be in a position to treat more individuals. In terms of our outpatient clinics, we have been able to run those. We did do those as remote consults by and large during the previous episode, but happily we're able to do in-person consultations, and we have continued to do those through the pandemic. It is our plan and expectation to continue doing them, and we feel more comfortable that we'll be able to do that, given that at the present time, we're seeing a fall in the number of our staff who have been off as a result of exposure or due to COVID. So that at one point we were well over 100 staff off. Now we are in the region of 70 or thereabouts. So it's trending downwards. It is a volatile process, so that could go back up. Nevertheless, we remain optimistic, we remain vigilant, and we have such safety measures in place that we expect that going forward, we will be able to manage our staff situation and continue to provide the services that people need. And this takes me to an important point. During previous waves, we have noticed a fall in the number of people coming to the emergency department. Here again, we're seeing that. And the concern would be whether or not there are people who do need the services and they're staying away. I wish for the public to know that we're open for business. And if you have some problem, be it chest pain, abdominal pain, weakness of the limbs, that could be a stroke, anything that is of concern, give us a ring or come on in. If you wish to call us, the number is 239-2009, or you can simply come down to the emergency department. We do not turn anybody away. If we ask about the vaccination status, it is for documentation purposes and to enhance communication. However, we will not turn away anybody irrespective of their vaccination status. So come on, we're here open for business and there to treat you and to give the best to every patient. And in closing, I would be remiss in not thanking the many staff at BHP, and particularly those in those services that were particularly affected in the early phase of this Omicron, when in the cleaning staff and many other support staff, they had to work extra hours as colleagues were off either due to exposure of their children or other matters related to COVID. And I wish to thank all the staff, and in particular, those in the support services who have risen to the task and covered for each other so that we could maintain normal and safe services. So thanks to all of them, and thanks for the cooperation of the public, and again, the Department of Health and the Minister and the Chief Medical Officer. Thank you.
Thank you. Thank you, Dr. Miller. Thank you, Dr. Ayo, and thank you, Minister. We will now take questions from the media, and we'll start with Jonathan Bell at the Royal Gazette. We will now take questions from the media. Jonathan, I need you to turn down your volume. Thanks.
I got you.
Thank you. Welcome, Jonathan.
Thanks. Checking as always. Are we up and running? Can you see me? Can you hear me?
Yes, Jonathan, we can see you and hear you. Thank you.
Thanks. Well, thank you for having us as always. Minister Wilson, I'm going to start with yourself. I'm going to try and corral all these together. We've got a lot of questions from parents, so I'm going to try and keep it tight. Why, in a nutshell, I mean, why are the restrictions in Bermuda for children so different from those in the UK when we've repeatedly heard talk about following Public Health England? In the UK, we have children who test positive. They can go to school after day 5 negative test. Children here are required to have 10 days out of school if they're even a close contact, and then they're masked all day at school. What's the scientific studies to support these restrictions? I hope you can appreciate there's a lot of questions from parents on this one. So
Absolutely, John. Absolutely, Jonathan. And before I turn it over to Dr. Ayoola, who obviously has far more expertise in this area than I do, I just want to just comment on two things. As we've always indicated, we will be looking at following as best as possible as a cabinet, considering what the scientific evidence supports. And we know that there is overwhelming scientific evidence that supports the wearing of masks minimizes the level of transmission of the virus. And again, I'll turn over to CMO about that. But I also want to recognize or remind members of the public that unlike in other jurisdictions where certain restrictions or clawbacks may be instituted, in Bermuda, we have one hospital. That's the only hospital that we have. And there's a huge difference between a country that has widespread community transmission and an NHS on every block. We have one hospital and we need to try as best as possible to ensure that we have regulations in place that will minimize the adverse impact on that hospital by being overwhelmed, as well as our healthcare system. So there are differences. We're not comparing apples and apples. We are talking about two very different countries with respect to the value, the mask resources that an NHS has, as opposed to one hospital. But insofar as the scientific evidence and the support surrounding the mask, I'll turn it over to the medical colleagues that are on the panel that can far best articulate the position more than I. Thanks, Jonathan.
thank you. Afternoon, doctor.
I'm just trying, trying to unmute myself. Hi, Jonathan. Yes, I also have had a lot of people make representations to me about what they consider the differences in our approach as compared to a place like the United Kingdom.
Yeah, I mean, they've dropped masks, haven't they?
Well, how much of that is following good scientific evidence and how much of that is political is a question that you and I can debate. But as the minister said, there are considerations around our acute bed capacity. I'm not going to expand on that. The minister's already talked about that. In Bermuda, a lot of people live in multi-generational households. We had plenty of evidence to show where transmission has happened in childcare type settings and people taking it back home to cause outbreaks in their homes and affecting, oftentimes leading to hospitalizations. There's a lot of evidence of that. We need, so what applies in a place like the United Kingdom cannot be transferred hook, line, and sinker to Bermuda. We need to make sure that we understand our risks. Even in the United Kingdom, there is a residual risk to what they're doing, and it's up to a quarter of people are still expected to be positive after 5 days. So we cannot afford to do that hook, line, and sinker in Bermuda. Having said that, though, my colleagues and I are looking at the evidence around this, and there's a lot more appetite by the cabinet now for more risk. We're looking at all the data that we have to see where we can make adjustments, because what all of us will agree on is that it's better for our children to stay in education, having face-to-face learning for as long as possible. That is what is good for our children, is what's good for our economy, and we'll do as much as we can to facilitate that.
While I've got you though, I mean, and this is obviously I'm not medical, but if Omicron is so transmissible, does that not render masking at least partially superfluous?
No, that's not that. No, it doesn't render it superfluous. Not at all. So it's, yes, as I mentioned in my presentation, it has a predilection for the upper part of the airway. So it means you have a lot more in the upper part of the airway. So talking, breathing, speaking, coughing means you can get a lot more of those viruses out. So where you have so in the old days where you had one layer of cloth mask, where people use one layer of cloth mask, that's not very effective. And we're asking people to have at least 2 layers, preferably the surgical masks, because that reduces quite significantly the amount of aerosols that's generated when people speak or breathe. So having mask is not superfluous. I would disagree strongly on that.
Yeah, I don't know. I was just asking.
Yeah.
Right. Got you. I had one specifically for the minister, piggybacking on the school question, but I think it's more appropriate for the minister. Minister Wilson, obviously there's this group, Us for Them. We've been hearing from them. They say they've been anxious to get a meeting. Why haven't you met with them? Or are you planning on meeting with this group? They say they've been trying for months.
I actually didn't know Us for Them has even been around for months, but let me just first start off by saying I respect this organization and I respect their the exercise of their democratic right to petition the government. I've received a number of emails from members supporting their particular cause. I've not been requested of a meeting with them. If that is something that they wish to do, I'm sure we could try to facilitate that. However, having said that, I think their biggest issue is the issue as it relates to mask wearing. And I'm following the advice. Beg your pardon?
It's a bunch. I mean, I tried to kind of corral them, but yeah.
Okay. I must admit I read about it today in your newspaper, but in any event, based on what the CMO has just explained as to the Omicron variant and the upper respiratory impact and what we know what a mask will do to help to minimize that, I think we may have to be in a position where we agree to disagree. But if, I've not been requested of a meeting. I have to say that.
Okay.
I have seen a number of emails saying, please reconsider the position. And as the CMO says, the cabinet does discuss these matters quite often. In fact, we have a cabinet meeting tomorrow for a number of matters. And the cabinet COVID committee meets every week to discuss issues insofar as how we address the restrictions and or rollbacks of the matters that are outlined in the Public Health Emergency Act.
Yeah, they say they'd like to talk, but let's move on. I haven't heard anything about SafeKey. It's from the sound of things, bars and restaurants are getting a real hammering. We hear a great deal from them as well. So if I'm a close contact, I can still go to work, but I can't go into a bar without SafeKey. What's the difference? Why are we doing that? What's the rationale behind that? The bar owners really want to know on that one.
Okay, well, if you're a close contact and you are quarantined, or you mean going inside as opposed to just sitting on the outside?
Be a different.
Because we've rolled back. Okay, because we have changed the rules as it relates to quarantine and isolation. But in any event, we have had discussions. The Premier has recently had discussions with the Chamber of Commerce concerning some of the matters that they've raised as it relates to SafeKey and how it is impacting on their industry. The cabinet are also in the course of having discussions surrounding that particular matter, and I would anticipate that there will be further matters discussed and disclosed to the public in the newness of time. I believe it was on one day last week when the Premier did his last interview with TNN, and he indicated that he would be addressing the nation on the 4th of February to outline a number of matters that the cabinet has considered and the government has considered as it relates to moving forward with living with coronavirus.
No, yeah, he did say that. I guess the crux of the question is what's the difference? Between a bar and a workplace, or hospitality and a workplace, we can be quite close together in a newsroom. What's the difference?
The principal difference is when you're in a bar, you're probably consuming alcohol. And oftentimes when one consumes alcohol, regardless of the quantity, inhibitions are reduced and removed. You have music around you, so it's easier to try to shout so that the person that's sitting next to you is able to hear your conversation. So you have kind of a mixture of the alcoholism, which makes your inhibitions go down, as well as the fact that you're not normally you probably don't sit in your newsroom and yell across the hall to somebody across the room to somebody. But if you're in a bar and you've got music around you, you're probably going to elevate your voice so that your points can be made and be heard. So that helps to cause more spray, just by human nature of speaking louder and yelling to try to be heard, as well as the elements of intoxication. So there are increased risk in those atmospheres.
Okay, I'm going to try and move along quickly here. We've got a query here on seeming discrepancies in capacity limits. Football, we've got 250 people. Others is 20, 50. It seems a bit arbitrary. Why was there a 100 limit announced when we've got football matches with 250 people allowed? And I guess why have a cap of 20 maximum in a group when we can have exceptions? It seems a bit arbitrary.
Right. You would know that the regulations do provide for large group exemptions.
Yeah.
Excuse me, the large group maximum is 20 currently under the public health emergency order, and there are exemptions that can be made. And I would invite you to speak directly to the Minister of Youth and Sport, who has the power to grant those exemptions, and he can provide you the rationale behind that.
Minister, thanks. The last two I have would be for the CMO, but thank you for having us.
Thanks, Jonathan.
Cheers. Dr. Ayoola, got a couple here for you, and they'll be quick ones. Oh, there you are, sir. Thanks. On behalf of physicians that have been in touch with us, they really, they get ticked off about the term immunized when plainly people aren't getting immunized. They say it fuels the belief for some that the vaccine is falling short. It's a term of art, I guess. Perhaps, I guess what I'm hearing is, can you maybe consider changing to a different term, protection or something? It just seems like immunized seems like it's been a problem from the get-go. What's the rationale for it? Is that a standard term for vaccination? They've been in touch with me on that.
Okay, I'm not quite sure I understand the ask, but
well, if I'm double boosted, if I'm double vaccinated, sorry, I'm not immunized. Right. It's not like a polio or smallpox vaccine. It's more like a flu shot, where I wouldn't say if I was immunized if I'd had a flu shot. That's what I've been hearing from some in the medical community.
Okay, well, I think it's a matter of semantics, and people use those words interchangeably with vaccination, and we've taken that made that distinction about people who about having two shots as opposed to one shot for the Pfizer vaccination and the AstraZeneca vaccination that we've had at the start of this. So the evidence we had at the start of this was based around, all the trials that were done was based around two shots. Now there's more evidence coming up to show that actually the third shot is almost as important as the original primary shots that we originally thought was what we needed. So again, the science and the evidence around this is evolving, and we're keeping up with this. So the language, yes, we can agree on what sort of language we want to use, but I don't agree that using that term immunized suggests that the vaccine isn't effective.
Okay. I just get it from doctors whenever I use it, but I'll just pass that on. Last one for you, Dr. Oyinloye. It's one that we raised back in December. I want to try and address it now. It's in terms of people who've recovered from COVID-19 and either getting very sick again or morbidity. We've been trying to clear this one up. Have we been seeing people who have recovered from COVID subsequently getting seriously ill? And have we been seeing any morbidity in this specific category? I think we've gone far enough into it where if that is a thing, we can say if that's happening here in Bermuda. We've seen it in news reports elsewhere. Are you seeing any of that?
With this present wave, I haven't looked at it in any detail, but certainly we have had people during the Delta wave that that has had COVID in every successive wave. So yeah, it is possible for people to get infected because we're dealing with a different variant. The way the body's immune system works is you produce immunity to any foreign body that comes to attack you, but it's not always consistent. Because the way my body might respond to a particular virus might be different to the way your body responds to the virus. What is consistent, that is why we promoted vaccination, is the vaccine gives a measured template message for a part of the protein. So we can predict how that is going to, the body is going to react to that with a reasonable amount of certainty. So yes, you will find people who get infected with successive waves of COVID, and that's not uncommon. There's plenty of evidence of that. With this wave, I will need to check that out before I give a definite answer on that.
Yeah, I mean, put bluntly, just in late last year, we had funeral pages that we fill in a newspaper, and we saw a lot of them. This being presumably the aftermath of the Delta wave. It doesn't sound like you can really say yay or nay on that. Were you seeing any of that was really my question, or is it, I'm guessing you haven't, or?
So are we talking about this? I'm not sure we're talking about the same thing here, Jonathan. So we're talking about people
who've gotten sick and recovered and yet then seem to die within a matter of months after.
Oh, right. Okay. Well, it's difficult to be able to attribute those directly to COVID, although COVID could be a contributing factor, because this is a very nasty virus. It destroys so much of your body systems, weakens everything. So it takes only a little bit to push people over the edge.
All right. Thank you for that. I believe that's me done. Thanks, everyone. Appreciate you.
Jonathan, just one more thing. No, I just wanted to add something, Jonathan, that I failed to answer with respect to the distinction between sitting in a bar and a restaurant as opposed to in the newsroom, as you said, in an office. Presumably in the office, in your newsroom, you're wearing a mask. Whereas if you're in a bar, pardon me?
We have partitions, we use masking. We're careful.
Right. But in a bar, right. Whereas in a bar and a restaurant, obviously, if you're eating and drinking and consuming alcohol, you're allowed to take off the mask. So that's a huge distinction, which goes back to the point that the CMO raised earlier insofar as the importance of mask wearing. But I just want to clarify that. Thanks, Jonathan. Have a good evening.
Cheers.
Thank you, Jonathan. We'll now take questions from Gary Foster Skelton from the Bermuda Broadcasting Company. Welcome, Gary.
Good afternoon. Let me start my video. There we are. Thank you very much. Thank you, ministers. Thank you, Minister Dr. Miller, Dr. Oyinloye. I presume you can hear and see me? Yep. Good. So my first question is for Dr. Oyinloye. Can you help us get closer to the true number of active cases? We know anecdotally that some people who test positive on an antigen test choose not to follow up with a PCR test or necessarily report it to the ministry. So government has no record of these cases. Also, some people with mild symptoms are not taking the tests at all. Do you have any relevant data or modeling from other countries that might help you estimate how many active cases we have altogether? Might it be 10% more than the official test records show, 20%? What's your best estimate?
Okay, thank you, Gary. That's a very difficult question to answer because the same problem we have here is replicated across the globe. Most countries are underreporting of COVID for different reasons. Not everybody goes ahead to test, and as you said, some people who test choose not to report their symptoms. So it's quite difficult. So to be able to understand exactly what the burden of disease is, the guess that the estimate I've seen for some people is asking to add between 25 and 50% more than the figures that we get through our normal surveillance purposes. If that applies to Bermuda, I don't know if that applies to Bermuda. It's really, really difficult without going out to actually study this.
Okay. 25 to 50% more is what did that statistic come from?
It's from the United Kingdom.
Right, thank you. This question is for the Minister of Health, you've explained that there is a shortage of Pfizer vaccines for children and its composition or formulation is different than the dose used for adults. You've also explained that you are seeking help through the US consul and the private sector. A two-part question: is there any breakthrough in sight? And the FDA approved the vaccine for young kids 4 months ago. Would you be willing to concede that Bermuda is now lagging behind many countries around the world and that you might have planned better for the child vaccine?
I'll start by addressing your question, Gary, in the reverse order. No, I wouldn't accept that Bermuda is lagging behind other jurisdictions. As the CMO has indicated previously, the MOU that we have is with the United Kingdom. They're the ones that are supplying us with the Pfizer. So we have certain terms and conditions that we have to adhere to that are related to the United Kingdom as opposed to the FDA in the United States. So that's the first one. And we've spoken about that previously as it relates to the importance of that MOU. We're getting the Pfizer from the UK, so the MOU has parameters of how we can administer that vaccine. Secondly, as we've also indicated, regrettably, there is a worldwide shortage on the pediatric dosage of the Pfizer. The CMO, as well as other persons in the ministry, have been making contact with the U.S. Consul General, so we are trying to have them assist in facilitating us receiving the pediatric doses. We're continuing on that. We haven't given up. We will continue to make inroads, and we're confident that the U.S. Consul General will do all that she can do in her power to assist Bermuda in facilitating the acquisition of the pediatric dosage.
It's still up in the air, or is there any particular breakthrough in sight?
I'll yield to the CMO, but we only just found this out a little while ago that there was a shortage in the United Kingdom. So we immediately have started our negotiations and our discussions with the U.S. Consul General, who is a very dear friend of Bermuda and has assured us that she will do all in her power to try to help us source that.
Yeah, if I can add to that, Gary. So yes, the Minister is absolutely right. There is a worldwide shortage of this particular formulation, the 10 microgram formulation used for the 5 to 11-year-old age group. So it's worldwide. The United Kingdom, for instance, does not have it yet. Much of Europe don't have it yet. The United States does have it, but that's probably because of their market size and how much they're able to pool in the market. And you did hear the minister say that when working with our friends and colleagues to see how we can source that from them. I have, in addition to that, the United Kingdom is expected to have some doses delivered at the end of this month. When we will get some, when any of the overseas territories will get some, it's still up in the air. But as of the discussion we had earlier on today with my colleagues, that still hasn't arrived in the United Kingdom. So it's not, first of all, I disagree that we're lagging behind. The Bermuda Advisory Council on Immunizations already approved this first week in January. But we can't.
But we don't have.
Exactly. We can't, it has approved its use, but we cannot give it because we simply don't have them. And we're not unique. Several other countries in the world are in exactly the same position that we are in.
Although countries some of the closest countries to us, US, Canada do have it at this time.
Going back to the point I made, that all depends on the size of your market and how much you're able to negotiate with your manufacturers. Bermuda, with our 65,000 population, cannot hope to outbid the US with over 300 million people.
Well, just to clarify on the MOU as well, government told us that because it's a different formulation, to use a smaller dose of the adult Pfizer vaccine that we do have would actually be to use it off-label. It's not recommended. Would that also, would that be prohibited by our MOU with the UK as well?
No, it's not prohibited by MOU with the UK. So the UK is using the adult formulation for its vulnerable children at this point in time, not for all children. But we have had extensive discussions with our pediatric community in Bermuda, and the advice from them is to wait until we get the pediatric formulation.
Okay, so what you're telling us is the UK itself has no vials of the Pfizer children's vaccine. They're simply just using a smaller dose of the adult vaccine for vulnerable children and those who live with immunocompromised. Right.
Correct.
Thank you for clarifying that. So I'm going to move on to a different subject now, onto the schools. And this question is for Minister of Health, Kim Wilson. 3 things happened on the same day this week. We saw a sudden rise in coronavirus cases among younger children. Government reported that some parents had sent children to school before receiving virus test results, some of which were positive, and schools were put out on phase 1 protocols with masking for all children, including the youngest. You haven't said this directly, but can you confirm if the sudden rise in cases among under 10-year-olds was a result of transmission in schools?
I'm unable to say that. I don't have that information in front of me. I don't know. I know that there was we have seen increases. I don't know if the CMO can add, but there have been increases to of the active cases, and that information is obviously online, so you can see the percentage of individuals that are under 16, 18, et cetera. But
yes.
I'm not 100% sure what the question is. The sudden rise of.
Well, we saw a sudden rise. While other cases, active cases seem to be falling in other age groups, we saw quite a 52%, in fact, rise among under 10-year-olds. And on the same day that we saw that rise, there was an increase of masking in schools announced. Mm-hmm. And also the coronavirus update told us that some parents had sent children to school before receiving test results. I'm trying to join the dots here. Did we see, is this all happening because we had transmission in schools during these first few weeks of the term? And can the CMO answer that one?
Yeah, thank you, CMO.
Yeah, thank you. I think we may be overstretching the facts, Gary.
Okay.
The simple answer is the number of cases we're seeing at this point in time is overwhelming our capacity to do contact tracing in each and every case. So we cannot give you confidently the total proportion of what is transmitted from where. But generally speaking, what we have seen is that the bulk of transmission happens in the household, and we have a lot of evidence of transmission within schools as well. But the bulk of the transmission we're seeing is within households so far. But again, I need to caveat that heavily by saying that because we don't have the capacity to contact trace every single person, we don't have the information for all exposures in Bermuda. And if I might just quickly go back to the first question you asked, Gary, about not being able to capture all the cases. The goal of what we do in surveillance is to capture the trends. So it's almost never possible to capture every single infection. But what we are interested in is knowing the trends, and that allows us to be able to manage the outbreak.
Thank you, CMO. I have another question for Minister of Health, Kim Wilson. Prior to the beginning of the school term, the Bermuda Union of Teachers showed frustration that there had not been a meeting of the Education Emergency Measures Committee to discuss the school opening with teaching staff and other stakeholders. We learned that there was a meeting of the EEMC on January 10th, but that was after the fact, after school openings had already been delayed by the outbreak, after testing resources had become overwhelmed, all events that government had been warned about. I understand there had been no meeting of the EEMC in December to discuss the new year opening. How does government justify not talking with education stakeholders about COVID protocols for school reopening before actually reopening?
Gary, thank you for that question. And I'm certain that you would want to have the full details surrounding that so that you can conduct your report. I would suggest that you put that question specifically to the Ministry of Education. We're not part of the EEMC. I can't confirm or deny. I'm not doubting you, but I can't confirm or deny that there were meetings that took place between the Bermuda Union and teachers and the EEMC, I think you said, during December, because I wouldn't have been a part of that. So I would invite you to take that question directly to the Minister of Education, because they would have been the ones that would have been conducting those meetings.
I'm sorry, I need clarification here. Are you saying that the Ministry of Health is not represented on the Education Emergency Measures Committee when the Ministry of Health is the body that actually implements COVID or creates the COVID restrictions for schools?
The Ministry of Health creates the COVID restrictions and the regulations for the entire community. However, it is chaired by the Education Ministry. So they would be able to know insofar as what meetings took place, what was the composition of the persons that were engaged, what were the agenda items and so forth. I can't speak to that. I wouldn't be expected to speak to that. These meetings are chaired by the Ministry of Education. It is the Union for the Teachers and the Ministry of Education that have these regular meetings.
Okay.
So I would invite you to speak to them.
Very well. The Ministry of Health is not represented in these at all.
We have a technical officers at those meetings, correct.
So, but with the technical officer there, you're not able to give us any thoughts on the fact that these decisions were made and there was no meeting prior to the opening of schools.
If you genuinely want an answer that you would like to report on with the facts, then I would invite you to speak directly to the Ministry of Education. It's their meeting. It's their union. They would be able to tell you when they met, what were the agenda items, what was the discussion items, etc. Health is there as a technical support, but leading these meetings is education and the union, and I invite you to speak to them.
Very well. Very well. Then my final question is for Dr. Miller, and staying on the subject of children getting the virus, Bermuda Broadcasting has been informed that between December 1st and January 26th, the hospital recorded 24 visits to emergency for children with COVID symptoms and one admission. Dr. Miller, how concerned should parents be during this time?
I would say that they should remain vigilant but not worried, in the sense that the thing with the present variant, like the previous variants, the severe illness tend to be seen more in those who have a weakened immune system or other multiple comorbidities. So that in practice, if we take the children, a healthy 5-year-old with Omicron or any of the variants, and if we were to compare that 5-year-old with somebody who was 70, who is overweight, diabetic, probably has chronic kidney disease, then for the same level of infection, the same level of exposure, that adult is at far greater risk than the child. What I would say to them, however, is that we're mindful of infection in the children, primarily because we're aware that the children do not live in isolation. And the grandparents will certainly want to visit, and the children really like to see the grandparents because, as you know, Gary, what they can get away with the grandparent, the parents tend to be stricter. So children gravitate towards the grandparents, and we therefore have to make sure we protect the grandparents. So in a way, we're a little bit unfair to the little ones because we have to say, no, you can't see grandma, not because of anything that they have done, but because there is that risk to grandma. So the concern really should be from the point of view of the child being able to transmit it to somebody more vulnerable in the household or the expanded family.
Just a note, cases among children do appear to be rising again. Well, cases overall in the UK appear to be rising, and particularly among children over the last week to 2 weeks. Does that represent a concern to add to that?
It is a concern, but not a worry. It's a concern and to some extent predictable, like in the UK and anywhere else, because children are social animals. You can't say to them, don't hug your friend, don't share a sandwich with them, that you can't be too close. They cough and then they remember, oops, I should have covered. They're not perfect, and so all the factors are such that they are more likely to be sharing their germs with each other. And this particular virus, because it concentrates so heavily in the upper respiratory tract, as opposed to, say, earlier variants, which were predominantly in the lung and elsewhere, is so easy to transmit that it's not surprising that once you restart school or you restart social activities, that would happen. But set against that background, I would still say to parents, don't keep their children away from school, because there is the yet unknown impact as to how the social isolation will affect these children. And also in terms of learning, there's a part of learning which we emphasize in terms of learning the alphabet and the prescribed textbooks. But when we look back at life, a good bit of our learning was from our peers. And they miss that kind of interaction and learning. That's the informal part of learning, but it is important. So I would say to parents, notwithstanding the fact that yes, there is a risk of increased infection in that age group when they begin to socialize, they shouldn't make that their factor in not sending them to school. However, they have to be mindful and make sure that the elderly have their booster dose, so that when the grandma and the little one get together, she or he, the grandparent, is protected.
Thank you, Dr. Miller, and thank you, Gary Foster Skelton. That actually concludes our press conference today. Mr. Wilson, do you have any closing remarks, or Dr. Miller or Dr. Ayo?
Thank you, honey, and thank you to members of the press for their attendance this afternoon. Again, I just would like to remind individuals that we still are in the midst of a very dangerous and severe variant named Omicron. We can all continue to exercise personal responsibility, adhere to the public health guidelines, and do what we can to protect ourselves and protect others. Thank you.
Thank you. That concludes today's press conference.